Welcome to Lung Talks. In this two-part video series, we will be covering the latest ABPA guidelines, and in part 1 we will focus on diagnosis, classification and key clinical features of ABPA. This video will cover definition, ABPA Isham criteria, diagnosis of ABPA, ABPM, clinical and radiological classification of ABPA and differential diagnosis for ABPA. Allergic bronchopulmonary mycosis are complex pulmonary disorders caused by immune reactions mounted against fungi. Most common organism involved is Aspergillus fumigatus, which colonizes airways of patients with chronic lung diseases. Most commonly occurs in asthma or cystic fibrosis. However, allergic bronchopulmonary aspergillosis may occasionally occur even in absence of predisposing conditions and may also occur in other chronic lung diseases such as bronchiectasis and chronic obstructive pulmonary disease. ABPA and ABPM. Conventionally, the term ABPA is used when causative pathogen is Aspergillus fumigatus. In contrast, allergic bronchopulmonary mycosis refers to an ABPA-like syndrome caused by fungi other than Aspergillus fumigatus. Among the allergens involved in asthma, Aspergillus fumigatus generates significant interest because the fungus grows within airways. ABPA clinical importance. ABPA responds exceptionally well to a specific form of therapy. Accordingly, ABPA is considered an asthma endotype and treatable trait in patients with cystic fibrosis and non-cystic fibrosis bronchiectasis. Early identification and treatment of ABPA are crucial to prevent progression of bronchiectasis. Regarding the ABPA Isham diagnostic criteria, diagnostic criteria proposed by International Society for Human and Animal Mycology ABPA Working Group in 2013 are widely used for diagnosing ABPA. However, since the publication of these guidelines was about a decade ago, new evidence has emerged regarding performance of diagnostic tests for ABPA. Nomenclature of allergic bronchopulmonary mycosis. Most common form of allergic airway mycosis is allergic bronchopulmonary aspergillosis, while allergic bronchopulmonary mycosis is much less common. Because there is considerable overlap in antigen repertoire of different Aspergillus species, the DCG recommended using the term ABPA when allergic mycosis are caused by any Aspergillus species, and term ABPM should be used when disease is attributable to fungi other than Aspergillus species. Fungi responsible for ABPM. Several fungi have been implicated in allergic bronchopulmonary mycosis. Most common organisms includes Bipolaris species, Schizophyllum commune, and Curvularia species. Candida albicans has also been reported in several cases of ABPM, although its pathogenic role remains uncertain. Prevalence of Aspergillus sensitization. Aspergillus fumigatus is the most common fungus associated with allergic sensitization and allergic bronchopulmonary aspergillosis. In a recent meta-analysis, the pooled prevalence of Aspergillus fumigatus sensitization among asthmatic adults was approximately 25% in tertiary care settings. Among individuals who are sensitized to Aspergillus, nearly 37% may develop ABPA. Population-based studies have also shown that prevalence of Aspergillus sensitization is around 16 to 17%. Screening for Aspergillus sensitization. Most patients with ABPA have moderate to severe asthma, although some patients have only mild asthma. Therefore, screening based solely on symptoms or asthma control may miss several cases. Given the high prevalence of Aspergillus fumigatus sensitization and possibility of ABPA among sensitized individuals, all asthmatic adults seeking tertiary care should be evaluated for sensitization against Aspergillus fumigatus. Screening is essential because ABPA can occur even in mild asthma and may progress to bronchiectasis if it remains undetected. Other fungal sensitization and screening in children. Other fungi including Candida, Penicillium, Alternaria, Cladosporium and Trichophyton have also been implicated in allergic sensitization. However, these fungi rarely cause allergic airway mycosis. Literature on fungal sensitization in children mainly relates to Aspergillus fumigatus and data on other fungi are limited. Based on expert consensus, screening for Aspergillus fumigatus sensitization in children is recommended only for those with difficult to treat asthma rather than for all asthmatic children. In next section, we will be discussing Isham recommendations for diagnosis of ABPA. Recommendations on lab evaluation and diagnostic cutoffs. In asthmatic patients who demonstrate Aspergillus sensitization, further evaluation should include serum total IgE, Aspergillus fumigatus IgG, and peripheral blood eosinophil count. For interpreting Aspergillus specific IgG levels, population specific cutoff values should be used whenever possible. If such data are not available, manufacturer recommended cutoffs can be used. The recommended diagnostic thresholds include a serum total IgE level of at least 500 international units per ml and blood eosinophil count of at least 500 cells per microliter. Microbiology imaging and procedures. Guidelines do not recommend using serum galactomannan for diagnosing ABPA. Sputum fungal culture may be performed during evaluation because it may help identify the fungal species or gate therapy. In cases of allergic bronchopulmonary mycosis, sputum fungal culture is recommended during evaluation. For imaging, a thin HRCT is recommended at baseline in patients with suspected ABPA to identify bronchiectasis, mucus plugging, high attenuation mucus and other abnormalities. Chest X-ray may be used to assess treatment response. Bronchoscopy, however, is not routinely recommended for diagnosing ABPA. Evolution of diagnostic criteria for ABPA. Allergic bronchopulmonary aspergillosis was first described in medical literature in 1952 by Hinson and colleagues. Later, first formal diagnostic criteria were proposed in 1977 by Rosenberg and colleagues. Later, Nelson and colleagues developed the first diagnostic criteria specifically for ABPA in patients with cystic fibrosis. In 2003, the Cystic Fibrosis Foundation Consensus Conference, led by Stephens and colleagues, proposed consensus criteria for diagnosing ABPA in cystic fibrosis. A major milestone occurred in 2013 when Isham ABPA Working Group introduced the first global attempt to develop objective and evidence-based diagnostic criteria. Recent modifications and Delphi consensus. Subsequent studies attempted to refine Isham criteria. Saxena and colleagues modified the Isham criteria using latent class analysis. In addition, Asano and colleagues from Japanese ABPM working group proposed criteria that emphasized fungal culture and mucus plugs. More recently, Delphi consensus guidelines were developed through a collaborative effort from Isham ABPA working group. These guidelines aim to simplify the diagnostic criteria and allow better identification and differentiation from ABPA and allergic bronchopulmonary mycosis. Diagnosis of ABPA. The diagnosis of allergic bronchopulmonary mycosis should be suspected in patients who have predisposing conditions such as asthma, cystic fibrosis, COPD, or bronchitis. It should also be considered in patients with compatible clinico-radiological findings such as expectoration of mucus plug, fleeting pulmonary opacities on chest imaging, finger in glove opacities, or lung collapse. For the diagnosis of ABPA, two essential components must be present. This includes presence of Aspergillus fumigatus specific IgE at the level of at least 0.35 kilunits per liter and serum total IgE of 500 international units per milliliter or higher. In addition to essential criteria, at least two other components should be present. This includes positive IgG antibodies against Aspergillus fumigatus, a blood eosinophil count of at least 500 cells per microliter, which may be historical, and characteristic radiological finding on thin section chest CT such as bronchitis, mucus plugging, or high attenuation mucus. Fleeting opacities on chest X-ray may also support the diagnosis. Important considerations in ABPA diagnosis. If Aspergillus specific IgE is not available, a positive type 1 skin test may be acceptable. Serum total IgE values below 500 may still be acceptable if all other diagnostic criteria are fulfilled. Aspergillus specific IgG can be detected using lateral flow assays or enzyme immunoassays. Importantly, high attenuation mucus on imaging is considered pathognomic for ABPA. Elevated IgE against recombinant Aspergillus antigens such as RASP F1, F2, and F4 also supports diagnosis. Diagnosis of ABPM. The diagnosis of allergic bronchopulmonary mycosis should also be considered in patients with predisposing airway diseases such as asthma, cystic fibrosis, chronic obstructive pulmonary disease, or bronchitis, or in those with compatible clinico-radiological findings. For the diagnosis of ABPM, the essential criteria includes elevated fungus-specific IgE levels along with serum total IgE level of at least 500 international units per milliliter or above. In addition to essential criteria, at least two additional findings are required. This includes fungus-specific IgG antibodies, blood eosinophilia of at least 500, and microbiological evidence such as 2 sputum cultures or 1 bronchoalveolar lavage culture demonstrating the causative fungus. Radiological findings similar to ABPA including bronchitis, mucus plugging, high attenuation mucus, or fleeting opacities on chest X-ray also support the diagnosis. Several important considerations also apply to diagnosis of ABPM. Clinical features such as expectoration of mucus plugs, fingering gloves, appearance, and lung collapse may be seen. In ABPM, Aspergillus fumigatus specific IgE should be below 0.35 kilunits per liter. Positive type 1 skin test may support the diagnosis. Serum IgE less than 500 may still be acceptable if other clinical criteria are fulfilled. High attenuation mucus is considered pathognomic for ABPM. Finally, absence of IgE antibodies against recombinant Aspergillus antigens such as RASP, F1, F2 and F4 excludes ABPA and strongly supports the diagnosis of ABPM. Diagnostic algorithm for ABPA and ABPM. The diagnostic evaluation begins in patients who have predisposing conditions or compatible clinical presentation. First step is to assess Aspergillus fumigatus specific IgE levels. A value of 0.35 KUA per liter or higher indicates sensitization. If Aspergillus fumigatus specific IgE is negative, the possibility of allergic bronchopulmonary mycosis due to non-Aspergillus fungi should be considered. In such cases, repeated isolation of non-Aspergillus species from respiratory samples is assessed. If sensitization to implicated fungus is demonstrated and serum total IgE is at least 500, the diagnosis is further supported by at least 2 additional findings, which may include blood eosinophil count of 500 cells per microliter or more, fungus-specific IgG, fleeting chest radiographic opacities, or abnormal chest CT findings. When these criteria are satisfied, diagnosis of allergic bronchopulmonary mycosis (ABPM) is established. Now, if Aspergillus specific IgE is positive, the next step is measurement of serum total IgE with a threshold of 500 or higher. This is followed by evaluation for blood eosinophilia of at least 500 and elevated Aspergillus fumigatus specific IgG or detection by lateral flow assay. Subsequently, thin section HRCT is performed to identify characteristic radiological features. Based on CT findings, ABPA can be classified into different phenotypes. If bronchitasis is absent, the condition is classified as serological ABPA or ABPA-S. If bronchitasis is present, ABPA-B. If mucus plugging is identified, ABPA-MP. And when high attenuation mucus is present, ABPA-HAM. If imaging demonstrates chronic pleuropulmonary fibrosis, disease is classified as ABPA-CPF. Thus, the algorithm integrates the clinical presentation, immunological tests, lab parameters, and imaging findings to establish diagnosis and classify disease phenotype. Differential diagnosis of ABPA. Differential diagnosis of allergic bronchopulmonary aspergillosis and allergic bronchopulmonary mycosis is broad, and caution should be exercised when making diagnosis, particularly in patients without asthma or cystic fibrosis. Elevated Aspergillus fumigatus specific IgE and IgG may also occur in other respiratory diseases such as COPD, pulmonary tuberculosis, and bronchitis. Patients with chronic pulmonary aspergillosis may also show elevated Aspergillus fumigatus specific IgE, total IgE, and Aspergillus fumigatus specific IgG. Another important differential diagnosis is Aspergillus or fungal bronchitis. This condition is characterized by at least 2 respiratory samples yielding same fungus and may be associated with raised Aspergillus fumigatus IgG and bronchitis. but these patients do not fulfill diagnostic criteria for ABPA. Similarly, patients with severe asthma may be sensitized to Aspergillus fumigatus and other fungi and have elevated total IgE. If they do not meet ABPA criteria, they are classified as severe asthma with fungal sensitization. Patients with ABPA may also have underlying causes for bronchitis. These causes may include immunodeficiencies, ciliary disorders, or mycobacterial infections. Therefore, it is important to search for other causes of bronchitis when evaluating these patients. The diagnostic workup may include a complete blood count, Aspergillus fumigatus, specific IgE testing, sweat chloride testing, measurement of immunoglobulin levels, and mycobacterial cultures from sputum. If the initial evaluation is negative, whole exome sequencing may be performed to identify conditions such as primary ciliary dyskinesia, primary immunodeficiency, or atypical cystic fibrosis, particularly in patients who have extensive bronchitis and recurrent infections since childhood. Coming to the last part, clinical classification of ABPA. Clinical classification of ABPA includes several stages and clinical situation. Stage 1, acute ABPA. Acute ABPA refers to newly diagnosed disease in patients who meet diagnostic criteria for ABPA or ABPM. Exacerbation occurs in patients with previously diagnosed ABPA and is characterized by sustained clinical worsening more than 14 days, radiological deterioration, and increase in serum total IgE by at least 50% from previous stable value after excluding other causes of worsening. Asthma exacerbation refers to worsening respiratory symptoms lasting for at least 48 hours without immunological or radiological evidence of ABPA deterioration. And infective bronchitis exacerbation refers to clinical deterioration of at least 48 hours with symptoms such as increased cough, breathlessness, increased sputum production or purulence, fatigue, malaise, fever, or hemoptysis. Again, without immunological or radiological deterioration of ABPA. Next stage, response to treatment. Treatment response in ABPA is defined by improvement in symptoms and objective markers. A response is considered present when there is at least 50% symptomatic improvement after 8 weeks of therapy, along with either significant radiological improvement or a decline in serum total IgE by at least 20%. Remission. Remission is defined as sustained clinical and radiological improvement for at least 6 months while the patient is off glucocorticoids and without significant rise in serum IgE. Patients receiving biological therapy or long-term antifungal treatment may also be considered in remission if these criteria are fulfilled. Next one is treatment-dependent ABPA. Treatment-dependent ABPA refers to patients who develop 2 or more exacerbations within 3 months of stopping glucocorticoids or who show worsening respiratory symptoms with radiological deterioration or a significant rise in IgE during steroid taper on 2 occasions. Advanced ABPA. Advanced ABPA represents severe disease characterized by extensive bronchitis involving 10 or more lung segments or complications such as pulmonary or chronic type 2 respiratory failure. Radiological classification of ABPA. Radiological classification of ABPA. Radiological classification of ABPA is based primarily on chest imaging findings. Serological ABPA refers to patients who meet immunological criteria for ABPA but have no bronchiectasis on imaging. ABPA with bronchiectasis is diagnosed when bronchiectasis is present on radiological imaging. ABPA with mucus plugging refers to patients who have mucus plugging without high attenuation mucus. Patients who have both bronchiectasis and mucus plugging are also classified under ABPA MP. ABPA with high attenuation mucus is characterized by presence of dense mucus within airways, which is a distinctive radiological feature. Most advanced radiological stage is ABPA with chronic pleuropulmonary fibrosis, which includes findings such as pulmonary fibrosis, fibrocavitary lesions, fungal balls, or pleural thickening. These are the HRCT images showing the different radiological classifications of ABPA. First one is ABPA S, second one B is ABPA B, characterized by bronchiectasis, and we can see mucus plugging in C, and D is showing ABPA MP with bronchiectasis as well as mucus plugging, and ABPA HAM is seen in E and F, and G and H shows the images of ABPA chronic pleuroparenchymal fibrosis. Additional radiological findings in ABPA. In addition to defined radiological categories, several other imaging findings may be seen in ABPA. This includes consolidation, centrilobular nodules with train bud appearance, atelectasis, and mosaic attenuation on chest imagings. In patients with chronic pleuroparenchymal fibrosis of ABPA, it is important to exclude chronic pulmonary aspergillosis as a potential complication.